Thanks for joining us for Clinician's Brief, the podcast, the conversations behind the content. I'm your host, Dr. Alyssa Watson, and in this podcast, we sit down with the authors of our favorite Clinician's Brief content to ask some practical questions that we know you at home want answers to. Joining me today to talk about managing canine and feline seizures is Dr. Liz Thomovsky. Dr. Thomovsky is an associate faculty member at Purdue University, and she recently wrote a quiz on this topic for Clinician's Brief that's very popular. And so I'm really excited that we can sit down and explore this a little bit further. How are you doing this morning, Dr. Thomovsky?
Not bad. About lunchtime here. It's a nice sunny day, so it's a decent day to be out and about.
All right, that sounds great. Before we jump into this, would you mind telling the audience a little bit about your background?
Sure. So I went to, everyone always cares about vet school on, right? So I started my vet schooling in University of Missouri, Columbia, and I was there for obviously the 4 years of vet school. I did an internship at University of Illinois in Champaign-Urbana. After that, I was like, I don't know about this specialty medicine thing. I think I need to go out and experience real life. So I worked for 3 years as a general practitioner in 2 different practices in Pennsylvania. One was a small, 2-man practice. Outside of Philadelphia. I did that for about a year. Various reasons it wasn't a perfect fit for what I was looking for. So I moved to a second practice in York, Pennsylvania, which is southern Pennsylvania near Baltimore. And that was a little bit higher volume clinic, a few more doctors, a little bit faster pace. So I liked it a little bit better. So I worked there for 2 years. And during that time, I started doing some extra emergency work on the weekends, make a little extra money, how it is. And actually, I hated doing emergency work when I was an intern. I hated it. That was my worst thing when I was an intern. But I enjoyed it when I went back to it when I was in practice later. And I kind of got to the point where I was enjoying the emergency shifts more than the regular day-to-day practice shifts, largely because I didn't have to, my number one reason is I didn't have to keep following up with clients again on the phone, calling them a million times. So then I decided to kind of shift my focus more to emergency. And this kind of eventually brought me to applying to an emergency critical care residency, which I did back at Missouri, my alma mater. And then I finished that. And then I went to work at University of Wisconsin for 3 years and froze to death up there for 3 years. And then when I decided I want to chip off the Arctic chill, I moved to Indiana, which is much warmer, more temperate climate. And that's where I've been, I think, a long time. I've been here since about 2011, so a long time here at Purdue. So I kind of got stuck here. So I've been here for quite a while. And so there you go.
Well, I'm sure they're happy to have you there. So I hear you. I went to undergrad in Minnesota. Same thing. So cold. Yep. Cold. So, and those that listen at home know I'm in Vegas now, so I don't do the cold. So, well, what we're talking about today, is we're going to be looking at kind of the varying clinical presentation of seizures, what in-clinic diagnostics and treatments are most effective. But before we dive into that, could we just get just a quick little refresher on kind of the pathophysiology of seizure and how specifically does status epilepticus differ from something like cluster seizures when we see it in the clinic?
So, by no means am I a neurologist, but essentially seizures are just disordered electrical activity in the brain. So it may be a little bit more activity than usual. It may be the same volume, but it's very disordered and it's not going from point A to point B as it should. And so as a result, it ends up essentially that your electrical signals get crossed, for want of a better term, and it leads to seizure type activity. Status epilepticus, which is actually probably the least common thing I see on emergency, is a long unbroken seizure that lasts for more than about 5 minutes is, I think, the classic definition. So going on for more than 5 minutes, constant seizure activity is technically status epilepticus. Neurologists also say that if you have a seizure, stop seizing, don't recover, and go back into a seizure almost immediately, with a very short period where you're not actively seizing, they'll typically call that status epilepticus as well. So that's status. Cluster seizures is where you have more than 1 to 24-hour period, but it's a discrete. You have the seizure, you stop, typically go back to normal or near normal or have a postictal period, but you're not seizing for quite a while, and then a seizure happens again. Duration between cluster seizures can be, anywhere from 5-10 minutes in between seizures to 5 or 10 hours in between seizures. So clusters just by definition just more than one in the course of a day. And then of course you have your single seizure. That's just one, and then it's days or weeks until you have another one. So, yeah. And so the ones we worry about emergently are when you have more than one per day, or when your seizure is not stopping. You have the status epilepticus event.
Right.
So.
And that actively seizing patient, that's one of the things that is really kind of a more common, emergency encountered by, general practitioners. Somebody will bring in their dog, either actively seizing or they just had a seizure that morning or something like that. And this is often kind of stressful for the staff. So what kind of triage strategies are there for the clinic staff that can help make these presentations, go smoother?
So I think the biggest thing is just remain calm. I mean, like everyone's like, "Oh my God, you had a seizure, you're going to die while you have a seizure." It's actually really uncommon to die when you're having a seizure, unless the seizure's been going on for so long that you become hyperthermic and had a variety of other things occurring because of almost like a heat stroke type event. Because you get so hot, that's when you tend to have animals that die during seizures. You of course can have with prolonged seizures, brain damage where they're not normal, have neurodeficits, things like that. But honestly, those are the exceptions rather than the rules. So most of the time they come in, the owner's freaking out. It was a fairly short seizure. They haven't been seizing that long. Especially in practice, your clients are not that far away. Most of the time 30 minutes or less.
Mm-hmm.
So remain calm. Hey, it looks like a seizure. It's a seizure, or what they're describing sounds like a seizure. As far as the staff goes, I mean, I think the big things are to get a TPR. And let's just assess the patient. Are they hot? Do they need to be cooled down? What's their heart rate, respiratory rate, things like that look like? And then all I really look for my technical staff to do is to kind of get that assessment, give me a body weight because I need to be able to medicate if possible, give me a body weight, and then just try to get a catheter, like venous access. And my part typically is to be like, oh, usually from a distance, you're like, oh, the doctor, you're like, oh, it's seizing. How hot are they? Okay, they're not too hot. Great. And then, let me get some benzodiazepines, because typically the vast majority of seizures will respond to benzodiazepines fairly quickly. Like I give the benzos, as I'm giving them, they stop having a seizure. So diazepam, midazolam, whatever your benzo of choice is. So I think big thing is make sure they're not hot. When you're putting the catheter in, I would check a blood glucose, because some animals will become hypoglycemic as a result of seizures, or seize because they were hypoglycemic to start with. So let's make sure that that's not the issue, because we need to treat that acutely. And then, after your TPR and a body weight, give me a catheter and I'll get the benzos. And obviously, if they're struggling with catheter placement, animals moving too much, whatever, you can always give things like midazolam per nose, or you can give your diazepam per rectum if you need to. So you have those options as well.
Sure.
And usually, like forever, but it doesn't take that long to do all that.
Right. And so if possible, it sounds like intravenous administration is preferred over those other routes. Would you say that?
Yeah. I mean, I think it works a little bit faster. You're sure the dose is fully getting in there. When you're giving, per nasal, the animal's moving its head and you're not sure how much got in the nose and how much got in the face or on you. Per rectum, sometimes you're like, is that stuff coming out of the butt, the diazepam I just gave? I'm not really sure, So, so IV is ideal, but I don't hesitate to give it the other routes, like if I need to.
Sure.
Per rectum is my favorite, because I can stick the syringe up and squirt. I'm not being bitten. I don't like the nose too much. It's too dangerous when they're biting things. So
yeah, I've also seen for the nasal, I've actually never used midazolam that way. I've never needed to, thank goodness. But I've seen kind of those little adapters or atomizers. Do you have to have those, or can you just squirt, your intravenous prep straight up the nose?
Yeah, you can just give it straight up the nose. That's how I've typically given it. But if you have the atomizers, if you give like a nasal vaccine and things and use those atomizers, those are totally fine to use. But like in the ER setting, like there's no vaccine, so we don't ever have rapid access. But if you have them, sure, go for it. But I usually just stick the syringe and just squirt and go, basically.
And do you use the same dose that you would be giving IV, or do you increase the dose at all when you're going these other routes?
So per rectum, for sure, you want to go like twice the dose. Per nasal is a little bit less clear. I usually give twice the dose as well. These benzos are super safe. So even giving twice of your published dose, so doing, 1 mg per kg of the Valium, the diazepam, or, 0.4 or 0.5 mg per kg of midazolam instead of 0.2. It's super safe anyway. And again, those other routes, I'm always afraid I'm not going to get the full dose in, especially the nose. So I usually just double both of them. So.
And you said that, this usually stops seizures right away, But what happens if it doesn't? Like, do you have a set protocol about how many doses of benzodiazepines you administer, and how long do you wait between doses?
So I kind of the standard answer I will give you, which is what we lecture on to the students and all that, is like if 2 doses don't work, stop giving it because it's not going to work in bolus dosing. So I'll give a dose, see if it works. If it doesn't, I'll give a second dose because then I'm thinking to myself, let's say I'm doing IV. I've given 0.5 mg per kg of diazepam, which is your standard dose IV, but the range is 0.5 to 1. So I figure if you give 2 doses, you're going to meet the high end of the dosing range. And if it doesn't work with that, like I said, I'll move to the next thing. But I would urge everybody, and this is the thing my sister wanted me to make sure I said. She's a neurologist. She wanted me to make sure to say, she's a veterinary neurologist, that we need to start the long-acting drugs ASAP. So even whether or not diazepam and midazolam work when you give them, you should give your dose of diazepam or midazolam and go get your phenobarbital and be giving that before you even decide if you need a second dose of the benzos, because the half-life of both those, the benzos, is so short that it wears off and they start seizing again, and we think the drugs didn't work. And it's probably not that. It's probably a lot of times the drug has worked or worked partially, and then they just start having a seizure again because the drug wore off. So But if I've given 1 dose and it worked, or it didn't work, and I give a second dose and it didn't work, and I've given my phenobarbital, which is what I usually reach for, maybe Keppra IV, and those don't work, usually I'm hoping that drug will work if the benzos do not. But 2 doses of benzos, like a standard answer, long circular response.
Okay. Do you ever have situations where you prescribe benzodiazepine or the benzodiazepines like midazolam or diazepam to go home, like for owners to give in emergency situations? And when you do that, I know there's some funny logistics in that. I think we used to have like suppositories compounded way back when.
Yeah. So me personally, and since I've become an emergency person, no, like I don't know these people from Adam who are coming in the door most of the time. Lots of the majority of emergency clients we're going to see one time and that's it. So I do not, because I don't have follow up with them.
Sure.
I know our neurology department does occasionally for some of their really bad seizure dogs have go home meds. And when I was in practice, I remember one dog that I did have Valium that I sent home with. So I don't think it's wrong to do it. As an emergency doctor, I just don't feel super comfortable with it, simply because I don't see these people again. And then I don't want them calling and refilling. And, there's so many emergency doctors. It's conceivable someone could call and I would refill a benzo, and then so would my coworker. And then we have a client who's using benzos for other reasons, But I think if you have a really good client-patient relationship, I would do it. And I've done it before and I would do it again.
So you had talked about, when they first come in, to go ahead and when you're getting that catheter, check that blood sugar. When you've got really small patients, because oftentimes these seizing patients are young, puppies or kittens or toy breeds, that are coming in, and their blood volume is really small. So besides that blood sugar, are there other tests that you prioritize in tiny little patients so that we can make every drop of blood kind of count?
Yeah, it's always hard because it depends on a little bit the history, a little bit the age. Is it a young animal versus an older animal? So young animal, any of the small guys you mentioned, everybody I check glucose on, quite honestly. But with a small little guy, I'm going to do a drop of blood for glucose for sure, because the little breeds and the babies like to get hypoglycemic. I often will put a drop of blood on a slide to make sure they have white blood cells and make sure they're not like septic for some reason, or young unvaccinated dogs and things. Not that parvovirus equals seizures, but do they have something else going on that's a comorbidity that caused them to get hypoglycemic? And I'll usually do a PCV. Those are probably the top, and a leukemia test and a CAP. Those are probably the top things I'm going to do with small amounts of blood. We have the ability to do an ammonia here in-house at the university. And an ammonia is, going to be, similar to doing your bile acids, checking for shunts and things, what's your liver function look like. And an ammonia only takes about 0.2 to 0.3 mils of blood. So in a young dog that I have a high degree of concern for a shunt, I may spend a couple drops of blood, so 0.2, 0.3 mils, and try to get pneumonia as well. The problem is, if you're not here, ammonia is not a practical test. You can't do that in most other practices. And bile acids and things take, more blood and time. So unfortunately, if I was not here, I wouldn't be able to test for shunts quite as easily as I do now. But yeah, so short answer here, PCV, drop of blood for looking for white blood cells, maybe looking for platelets, leukemia test if it's a kitten, and then I often do an ammonia for the little guys who are babies. Adults who are small, I still would do a glucose. I would often, adult can tolerate a little bit more blood loss than a puppy or kitten can. So if it's like a Yorkie or something who's a year old and having these weird signs, I would prioritize getting either ammonia testing or bile acids testing. It depends a little bit on the history. Like, what does it sound like? Are they getting insulin? Then, glucose might be all I care about because they're hypoglycemic is from the client. If they've been sick for another reason, they're on other medications, that might lead me. But I think, glucose testing, ammonia testing, and then a full chemistry in adult is nice. Or at least we have something called a NOVA, which does electrolytes and checks for azotemia, because renal disease is something I want to take off the docket for a lot of adult animals as well. And so whatever way you can get BU and creatinine that doesn't take that much blood is probably handy in an adult as well. You're less likely to see azotemia as an issue in like a puppy or kitten.
So looking at those bigger patients, where we don't have those, issues, or we don't have those concerns about taking too much blood, then you have everything you want. What are you looking for on that CBC and chemistry panel then?
So I always tell the students, you got to tell me 7 things. Like, you got to sell the blood work to the owner, number 1, and you got to tell me the 7 things you're looking for. And so, because I actually, I can remember when I first started working, I think I was in practice before I went to emergency practice. And I remember people come with seizures, and I really wanted to do blood work for the reason I'm going to say in 1 second. And I'd be like, okay, your dog just had a seizure. I know it looks totally fine now, but I want to do some blood work. It's going to be like, at that time, it was probably like $100. I mean, it was a long time ago. Now it's closer to 200, right? But, I want to spend that, $100, $200. And the client's like, no, he's doing fine. I'm going to go home. And you're like, what? Then off they go. But then I had this revelation, because on a side note, I also sell Tupperware, the greatest product. And when I started selling Tupperware, one of the lectures we went to was how to sell products, like make people believe the product is worthwhile. And I was like, wait a minute, why am I not doing that with blood work? And so therefore, my new spiel, which, I've been able to sell people on doing the blood work, because it is important, right? But I need to sell them on the value of spending that $100 to $200 on their pet that they weren't expecting to sell. So I always say there's 7 things that we're looking for. And depending on the client, I give more or less detail, because, some people want all the details. Some people can broadly characterize. But the 7 things are, you're looking for electrolytes, so sodium and calcium, and big abnormalities in sodium, either direction or the other. High or low can potentially cause, if not full-on seizures, awfully weird behavioral things that can look like a seizure. Hypocalcemia for your eclamptic dogs with hyperparathyroidism, and things like that. So low calcium can potentially cause you to have seizures, twitching, things like that. So electrolytes, those are my big 2. I want to check kidney function. And I have actually seen, weirdly, because I always said to myself, how often are you going to see an animal come in with renal failure, a seizure as their first clinical sign? More often than I thought.
Really?
So yeah, I can think of. I remember the first one I had, and I was like, that never happens, because I'm telling the people we're going to look for renal disease, and their animal had terrible renal failure, and that was the only sign they noticed was the fact that it had seizures, which I thought was super weird. But anyway, so renal failure, liver failure, liver functional failure, hypoglycemia, obviously. So those are your 5 things on your chemistry. And then on your CBC, you're looking for hematocrit abnormalities, so very low or very high. So very low, less oxygen in your blood, less oxygen in your brain, seizure. Very high, your blood is very thick. So high hematocrit, 70s, 80s. When they're hemoconcentrated, their blood is really thick. So the blood doesn't get to the brain, causes seizures. And then thrombocytopenic animals. We've had a couple that have bled into their brain, and seizure was the first sign that the owners noticed. So those are the 7 things. So for clients, like I said, I can give them all the detail, or I say I look for electrolytes, kidney and liver function. I'm looking for your red blood cells, and I'm looking for platelet abnormalities, because those can also cause it. But if you sell the value of it, I feel like much higher percentage of people say, okay, go ahead and do some blood work. But I also tell them, if I can rule these things, if I see any of these things happening, we can start treatment right away. Whereas if all this stuff is normal, we can feel safer having your dog go home and, kind of seeing how things play out. So.
And then oftentimes it is all normal. especially if we have idiopathic epilepsy or something like that.
Yep.
So what are we looking at for more advanced diagnostics, and how do you decide, prioritize which patients you recommend that for?
So advanced diagnostics are mainly going to be your MRI and CSF tap. So pretty much if the blood work is normal, you're going to have to look in the brain. We always joke that the reason MRI was created was to look inside the skull in the first place, right? So MRI and CSF, which obviously have to be referred 9 times out of 10, unless you're like I say, an ER like I am attached to a specialty clinic. And so most of the time, our neurologists don't like to always image animals that have just had a seizure, just had a couple of seizures. So a lot of times our imaging patients, the ones we end up referring for imaging, are those that we've tried some anti-epileptics for, they're continuing to have seizures, or the owner feels like the frequency of seizures is more than they're comfortable with despite medication. So especially in ones we suspect are epilepsy, we're almost always going to try drug therapy first. Let's see how frequent your seizures are. Let's see how many drugs you need, what have you. And then if you want to come back and talk to neuro in the next week or two about doing imaging, you can. If you want to see how it plays out with frequency of seizures, you can kind of see how it goes and then make your appointment to come back later. So that's kind of how we treat that. The ones we suspect are epilepsy. The ones we think are brain tumors, the older ones, and then the other side of the spectrum, the younger ones where we're worried about meningitises, encephalitises, and things like that, a little higher frequency. We will typically talk to them, right up front, hey, we can treat you with medications if you want, or if you're interested in imaging, it's never wrong to do that. Get your MRI and your CSF tap. And, some percentage of clients choose to say, some percentage of clients want to go home and see how things go with medication. But I always feel like it's our job to at least make clients aware right away that MR and CSF tap is what you would do next. And in some cases, it's a diagnosis of exclusion. So epilepsy, we're doing those tests just to make sure we find nothing else. And then if blood work is normal and those tests are normal, you must be an epileptic, right? Whereas in some cases, we're talking about those diagnostics because we're worried about underlying disease more. But I think it's always important to let people know that these tests are available first. And then if they choose to stay, great. If not, no. And then neuro usually makes a decision about exactly what day. If the owners are like, I want to image right away, neuro will decide, did the imaging happen, the next day, the next business day? Is it something they want to give the owner a day or two before they do the imaging? Because if there's lots of seizures, they can have cerebral edema just from having seizures that make the interpretation of the MR a little bit more difficult for them. So I usually leave the exact timing of the MR to the neurologist, but warn clients that even if they want to have imaging done, it may not be the next day. It might be you stay in the hospital for a day and then, we do it the subsequent day, something like that. Because I will say the number one complaint, quote unquote, that clients will tell us or the people tell us, and take it with a grain of salt, because we all know we say a lot of stuff that clients aren't hearing, don't listen, whatever. But people are like, I didn't know I could my dog is having all these seizures and I didn't know that I could come in for an MRI. And I'm always like, really? Your vet didn't tell you that? I'm having trouble believing that. But because of that complaint over the years, like I coach all of our ER doctors, like we need to make sure these people know that MR is always an option. Put in their discharge instructions. It's in black and white writing so that they know it's available. And if they're choosing to not do imaging, it's fine. It's their choice, but they just know it's available. So
that's really good insight. Thank you. You're busy. Your CE needs to be easy to earn and easy to track. Clinician's Brief CE is highly relevant and now more convenient than ever. Study online, from home, or on the go, and always at your own pace. Courses are race approved and designed with your busy schedule in mind. Start your next course today at cliniciansbrief.com/CE. So let's take a second and talk about seizure disorders in cats versus dogs. How do they differ?
So I think the biggest thing with cats is that, and actually, ironically, we had an epileptic cat when I was a kid. So weird, right? But their seizures tend to be, a lot of times they're more violent seeming. So like, the dog will just kind of like on their kind of quietly fall to the side, paddle, foam, what have you. Like it's like, oh, people make it drama, but the dog themselves is not really violently doing anything, maybe moving their mouths, what have you. But cats will like throw themselves across the room. Our cat, when I was growing up, used to be on her, like we had her on an elevated counter to eat, and she would throw herself off the counter across the kitchen. And we're like, oh my God, the cat's having a seizure, you know? So, so they tend to be a lot more like a lot of times more violent, like muscle movements. A lot of times they have a lot more dysphoria than dogs too. So they may vocalize more, seem more mentally out of it, like more dramatically mentally out of it for longer periods of time, that sort of thing. They have a lot more behavior changes pre and post, you know, that sort of thing as well than dogs. They don't have always, they can, but cats less likely have that classic paddling on their side thing. So cat seizures are a little bit hard to diagnose sometimes because of the fact that they look so different. Like your cat, like it's sitting on the bed and then it's on the floor and you're like, you know, what was that? Oh, it ends up that was the cat having a seizure. So it can take a little bit longer sometimes to, when you're talking to a client, like suss out what's going on. But yeah, I think more behavioral stuff, sometimes a little bit more violent and dramatic, and less like your classic dog seizure, I would say, is how they tend to look. So
recently, there was this classification system recommended for dogs by the International Veterinary Epilepsy Task Force. Can we kind of adapt that or use that in cats as well?
yeah, so I actually had to go look that up because I was like, what in the world are they talking about? Because you warned me you were going to ask me that. I was like, what in the world are they talking about? So I went and looked it up. And then I was like, okay, I have seen this. I didn't realize it was from a task force. So I asked my sister about it. Again, she's a veterinary neurologist. And she's like, yeah, that exists. We don't teach that to the students. And I was like, great. All right, good. Because I had not been using that. So her opinion is, it's kind of like relabeling what we used to say before. So, you know, it used to be like your generalized tonic-clonic seizures, your partial seizures. And it's kind of just like giving different names to it that are getting a little bit more of the etiology. So is it a reactive seizure, like reactive to light, like people get? Is it a symptomatic of another disease? You know, is it reflexive, I think is another terms. And she says, well, you know, the usefulness of that is like if you're a neurologist talking to a neurologist, you know, like it's a reflective seizure, then they understand what you're talking about. Is it important clinically? Most of the time in discussing a seizure, not really. And so she the whole group of neurologists here still kind of talk about your generalized tonic-clonic, your partials. But can you use the same thing for cats? Sure. But I was relieved to hear that they weren't teaching that because I certainly wasn't using that. I was like, oh, am I supposed to be using this? And she's like, we don't really teach it to the students. You're fine. I was like, okay, good. So can you use it for cats? Short answer, yes. Do we use it clinically? Is it that helpful clinically when you're not writing a journal paper or designing a study? Because I think for like studies and you want to make sure all these animals have this type of seizure, it makes total sense. But I think clinically, I don't know how terribly relevant it is for us. Just know that it's like they have facial twitching only. It's the whole body. I mean, that's kind of what we're going for. So.
Sure. No, and that's really good to know, you know, what these things can we adapt into the clinic and what's important that we need to be communicating to our clients too. So, I mean, that's great information. In your quiz, you know, you talked about phenobarb being really the most reliable anticonvulsant in cats. Why is that?
So when I went to look that up, when I was originally putting the thing together, it just works the best. I asked my sister, it just works the best. So pretty much consensus is phenobarb just works the best in cats as far as compared to all the other drug options that you have. So it's just, you're the most likely to get good resolution of seizures using phenobarb with cats. Also, cats have much fewer side effects than dogs do. So you're not going to see that horrible polyphagia, the PUPD that dogs get, the dramatic weight gain the dog gets because eating like a pig. That's really rare to see that in cats, or if you see it, it's much less extreme. It's like they're drinking a little bit more water, but it's not like gallons of water like some of these dogs will drink. Also, cats tend to get less sedated on it as well than dogs. So the side effect profile is way more, what's the word I'm looking for? Clients like the side effect profile in cats a whole lot better. It works well in them, and then it's only twice a day. And again, pilling a cat, I mean, I hate medicating my cat. So the less you have to medicate your cat, the better. And it's only twice a day, which is a big plus. So Team Neuro here, every book I found, every article I could find, it's like use phenobarb first. If that's not working, try something else in cats.
Well, the other nice property of phenobarbital, you talked about pilling cats. The other nice property of phenobarbital is there are actually transdermal, preparations for cats. And I'm always a fan of transdermals in cats.
Mm-hmm.
Are there any other seizure medications, any other anticonvulsants that have shown to be absorbed transdermally in cats or dogs?
Yeah, so levetiracetam, Keppra, definitely is tolerated in that it doesn't cause reactions transdermally. It does reach a blood level. Well, does get absorbed, and we don't know how much they get, and nor does anyone know what the Keppra blood level needs to be to stop seizures. But they have shown that when you give Keppra transdermally, it ends up in the blood. How much you need is quite up to question, but you do have the option to try Keppra, and there was recent-ish paper out about using, trying it in healthy cats, and it is well tolerated. So that's an option that you have. And other than that, I have not come upon any other transdermal preparations that I could find. It's pretty much Keppra. Well, try phenobarb first, and then Keppra phenobarb not working transdermal wise in cats, and then in dogs as well, because there wasn't any additional formulations that I could find that were dog only. It's just those two drugs, Keppra and phenobarb, are the only two that have been made transdermal so far that I'm aware of.
And yeah, I was really interested about that side effect profile because, I haven't treated a lot of epileptic cats. I know I've had one or two in my career and I've used phenobarbital, but I guess I didn't really realize that the side effect profile, was so much different in cats than dogs, which is really nice.
Definitely. It's usually the opposite. Usually everything with cats is worse, but not this time.
Right. So the other thing I've noticed just personally in the last several years is kind of this push to use some of those newer anticonvulsants, levetiracetam, like you said, or even zonisamide as first-line therapeutics in dogs. They've come down a lot in price. That was a big in the beginning of my career, that was a big hurdle, as those medications were really expensive. How do you feel? Do you feel they truly have fewer side effects? Do they require less monitoring?
So again, I consult with my sister on this since I don't get all of that follow-up on these cases.
Right.
But
Yeah.
we're always talking Keppra. Oh, no side effects at all. I would say it's been modified to very few side effects in dogs, but Keppra definitely has, as compared to phenobarb, in dogs, way fewer side effects. So you're not going to get the PUPD, polyphagia. The sedation is very minimal if they have it. It's generally, well tolerated, like i.e. no vomiting or diarrhea typically reported with that drug. So Keppra truly seems to have, no drug has no side effects, right? But very few side effects reported with that. So we use a lot of Keppra in our canine patients. So because we'll have that initial conversation, your animal needs a long-acting drug. Here's your two most common options that we use are phenobarb or Keppra. You kind of go over pros and cons of each for clients. And now that Keppra has come down in price and that you can get it in long-acting extended release, a lot of clients, and so it's only twice a day instead of 3 times a day. A lot of clients opt for levetiracetam because when you tell them, I'm going to guarantee you these 4 side effects in phenobarb, and we need to do blood work on you every 6 months to a year to check on liver values and things. Clients are like, ooh, but this other drug, we don't need to do blood monitoring. That's correct. Side effects we expect are very few, and I can give it twice a day. Great. I'll spend a little bit extra. And so a lot of clients have been opting for the levetiracetam. We don't use a lot of zonisamide here. When I did CE one year where I went to, it was NAVC VMX in Florida. And then the same year I went to Western and, obviously out in Las Vegas by you guys.
Yep.
It was weird because I did the same talk about like acute seizure management. And in Florida, everybody came up and asked me about Keppra and like my thoughts on Keppra versus phenobarb. And then in Las Vegas, everybody was using zonisamide. It was very strange. So it almost seems, and I asked my sister about it, she says there does seem to be, nobody knows why, like a coastal thing. Like West Coast likes zonisamide and East Coast tends to use levetiracetam more. We're kind of in the middle. So our neurologists all trained on the East Coast, so we use Keppra here. But they'll use zonisamide as like a second or third drug that they add on here. So I have not prescribed zonisamide myself. We've seen a few dogs come in through the emergency room who are on zonisamide, but usually they're coming in because they're having breakthrough seizures or something else is wrong with them. So I can't really comment. I know that like textbook wise, you're supposed to still have, there's been some anorexia reported with zonisamide. I think it's a little bit more feline than canine. And sedation is more likely with zonisamide than levetiracetam. But other than that, that's just me reading out of the book. I don't have personal experience with that drug.
I think you can get a polyneuropathy too, because I had that, like an immune mediated polyneuropathy with zonisamide, because I did have that once. That's so funny. Our neurologist trained at Iowa State, and she uses levetiracetam. So I'm going to do a poll on this now. Like, where do you practice, and do you like levetiracetam or do you like zonisamide?
Yes, because we use some, but not a lot here. And most of the practitioners around here, because we train them, are using levetiracetam. So, back when I started practicing, it was always potassium bromide. That was what we added on. If phenobarbital wasn't cutting it, we always added on potassium bromide. Has that really fallen out of favor? Have you seen that recently? Yeah, so me too. When I grew up, we used bromide for everything. And for me, when I was doing it, bromide was only liquid. So it was a pain in the neck, like a powder. We had to put, like on the weekends, I had to go and like mix it into a liquid. Very annoying in emergency, but I guess you can get it in capsules now. But I asked my sister about it again because I was like, what's going? And so it's not that it doesn't work. It's just that, especially when it's just a liquid formulation, you're giving a dog a huge amount of liquid. That was annoying. So when you could get something like levetiracetam, that was a pill or capsule, or zonisimade's a pill or capsule, that was really attractive to clients. Like, this is so much easier to give than, a gallon of liquid to my dog, that sort of thing. So I think that because of the formulation, it fell out of favor a little bit with that. The other problem was, although, did you know? And I didn't know this, that KBR, potassium bromide, is the only FDA-approved anti-seizure drug in dogs.
I did not know that.
No, I didn't know that until recently. But regardless, who cares? No, but but the other thing about when you do use KBR, because the potassium salt is bound to the bromide, you have to take into account what the patient's sodium, like what's the sodium level in their diet. And so animals who change diets a lot with different sodium levels, like the owner likes to change the diet for whatever reason, or where they're on a higher salt diet to start with, and that's just what they're on, it can mess up your dosing. So it looks like you're having breakthrough seizures because your drug isn't working, but it's not that. It's just you need to adjust the bromide in response to the sodium. And so that made things annoying using bromide long-term as well. Sure. You had to tweak it a lot more and change doses a lot more. And there used to always be like a big scare that if you had an animal in the hospital, you couldn't use bromide because the fluid dilution with the sodium-containing fluids would dilute the bromide and make it work less. Although I actually went to look that up because I'd always heard that. And I actually can't really find anything. I feel like that might be a bit of an old wives' tale, that part. But the salt diet for sure, because you're giving bromide orally and you're getting you're getting your diet obviously orally. That part for sure is real. So I think it's just like bromide's a little bit more annoying to use, and that's why it's kind of fallen out of favor. But it's very inexpensive and it still works well.
So it's an option. It's out there, just with a little bit more tweaking.
Correct. Yep.
All right. So we'll circle back to emergency and critical care with, cluster seizures, status. You talked about how those can be self-sustaining, and then they can lead to other, potentially fatal sequela. I will totally be honest. I had completely forgotten about the Cushing phenomenon. If I was taught it, I'm sure I was. But this is a response that animals and people get to increased intracranial pressure. So can you just walk us through those three main components to this reflex? And then also the big thing, what can we do, if we see this?
So Cushing's reflex is a little bit overdiagnosed by our younger veterinarians. So I think we must all come out of school having remembered this, because all of the interns that come are like, it's got Cushing's reflex. I'm like, no, it doesn't. But big things are, remember, to have a Cushing's reflex, your brain pressure is increased. So you're obtunded. Like, you're not BAR, biting me, running around the kennel. You're not doing that. Like, you're laterally recumbent, always pretty much, or at least like sitting there very, very out of it. So you have to be obtunded. Cementation is very abnormal. Your blood pressure is high and your heart rate is low. And the reason for that is, you guys may remember, cerebral perfusion pressure is the blood that gets up into your brain to feed the brain. And so that's to figure out what your cerebral perfusion pressure is, it's your mean arterial pressure minus your intracranial pressure. So mean arterial pushes into the brain, and intracranial pressure holds the blood from coming, holds blood out of the brain. So as your intracranial pressure goes up, you have to increase your systemic blood pressure to push the blood into the brain and overcome the intracranial pressure so you can still feed the brain cells with blood. So you have high blood pressure, and then your baroreceptors sense your blood pressure is high, and reflexively you lower your heart rate. So obtunded mentation, out of it, laterally recumbent most of the time, minimally responsive, high blood pressure, and low heart rate. Those are your big things with the Cushing's mechanism. And again, we'll see those like when you have high intracranial pressure, cerebral edema, things like that. So head trauma, stuff like that. So, my favorite thing I always kid my sister, like the thing about neuro is there's like 2 drugs you use. So you use benzodiazepines and your phenobarbital stuff
or prednisone.
So mannitol and steroids, that's all we're going to use.
Yep.
Guess what? Mannitol and steroids are what we use for this. So when you think you have like high intracranial pressure, we're going to give mannitol. And the idea is that's a sugar molecule. It sucks fluid into your bloodstream and then you pee it out. And so the goal is it's going to remove the edema in your brain. It also potentially has some like free radical scavenging effects and things like that. So mannitol and or hypertonic saline, your choice. So those are ER people especially like to use hypertonic saline. So that's, your normal saline is 0.9%. Hypertonic saline is like 5%. 9.5%, 7.2%. Like those are hypertonic salines. So lots of sodium. And so you can give that lots of sodium particles. Water goes into your bloodstream again, and you pee out the water. Maybe I'm old school. Like I typically use mannitol rather than hypertonic. It doesn't really matter though, whichever one you'd like. And then it never hurts to give a dose of steroids. And so if you've got edema from a tumor, it can help with that. And that's why your intracranial pressure went up. If you've got infectious or inflammatory disease, so meningitis, steroids can help with that. And then if the edema is vasogenic, meaning increased permeability of your vessels, steroids have been shown to help a little bit with that in the brain as well. So what do you use? You use mannitol and steroids as usual. So, and obviously if they're hit by a car or something, I guess I got to put in my standard thing. Make sure you resuscitate the rest of the body. So if they need IV fluids for the rest of their body being in shock, do that. That sort of thing. But mainly for high intracranial pressure, those two things, mannitol and steroids.
Those are the 2 that you're reaching for.
You got it.
Well, I learned so much today, and I hope our audience picked up some really useful pearls too. Hopefully, after listening, they can go take your quiz on our website,
Sure.
www.cliniciansbrief.com. There's a quiz on managing seizures in canines and felines, and they can score 100% on that.
That's right. There you go.
So the last thing we do on our episodes, there's one tiny little thing left. We actually have a quick game. It's just for fun. So you've answered all these wonderful questions for us, but now I get to ask you some just fun would you rather questions.
Okay.
So would you rather see nothing but surgical emergencies or nothing but medical emergencies?
I mean, if I'm feeling lazy, surgical emergency, because I don't deal with master.
Because you turf them.
Off they go. So those are like, I do something for a little bit and off they go. Less paperwork long term. Medical emergencies are a little more challenging, I guess. If I'm feeling like I want challenging, like I got to think about it, interpret blood work, then I'll go for the medical. So it depends on the day of the week.
Would you rather place an IV in a 1-pound dehydrated kitten or a 100-pound obese basset hound?
Well, that's funny you ask, because the joke here is that I don't ever place IV catheters because I can't do it. I'm terrible at it. So I don't know. I couldn't get either one of them in probably. So I literally, thank goodness I have an excellent, amazing nursing staff, amazing, and the students like to practice, good for me. So no, I don't know. I probably would have slightly better luck in the kitten simply because I could maybe see the vessel. If I have to go off a touch, forget it. So I'd probably put an intraosseous catheter in either one of those because I can't get that in.
Yep, exactly. I think with the kitten, the intraosseous would probably be the way to go. Okay, if you could choose, would you rather go forward in time 100 years and practice in the future, or would you rather go back in time 100 years and practice in the past?
See, 100 years, I'd be like, I want to be retired. That's a tough question. I mean, honestly, emergency stuff, we're not that high tech. I'd probably go back in time because I actually think one of the things we're losing over time is the ability to do a decent physical exam. And I do think 100 years ago, like, because that's all we had, we did really good physical exams. So other than the fact that there were no IV fluids, which would crimp my style 100 years ago, I probably would still go back in time. I go back in time.
You go back in time. That's awesome. Okay, last question. This one's the most important. So if you had Cerberus, the three-headed dog, come in on emergency, seizing, would you give the standard dose of anticonvulsants or would you triple it because of his 3 brains?
Tough call. I think I'd probably triple it. Again, they're so safe. We probably are not going to hurt him. So, and it might sedate him a little bit if we gave him a little extra. So I'd probably go triple the dose.
That's a good answer and really good reasoning.
There you go.
Well, that was it. That was all my questions. I hope it was fun.
Oh, yeah, of course. Absolutely.
Well, thanks again so much for joining us. This was a great conversation, and we would love to maybe have you on again in the future.
Yeah, sure. Anytime. If you want to hear me blab on and give very long answers to simple questions, I can do that.
They were excellent answers.
All right, well, good. Well, thank you very much. But thank you for having me on. It was very nice. Good time.
Thank you for listening to today's episode of Clinician's Brief, the podcast. If you enjoyed this episode, you can find us wherever you listen to your favorite podcasts, including a video version that's available on YouTube. While you're there, make sure you subscribe, rate, and review us. You can also listen to or watch our podcast episodes on our website at cliniciansbrief.com/podcasts. Or drop us a line at podcasts@briefmedia.com. Clinician's Brief, the podcast is a VetMedics production. Produced by Alexis Ussery and hosted by me, Dr. Alyssa Watson.